Welcome back, ladies and gentlemen. Now it's time to explore the subject of vaccination via the next symposium. Vaccination Frontiers from Rooting and Emerging Needs. This will be chaired by Dr. Madhuanti Hettiarachchi, consultant physician at Teaching Hospital Peradeniya, and Dr. Kanti Nanayakara, consultant in rabies and vaccinology. It's my pleasure to invite Dr. Hettiarachchi and Dr. Nanayakara to chair the session.
Good morning. Warmly welcome you for the next symposium on vaccine frontiers from routine and emerging needs. Our speaker is Dr. V. Ramasubramaniam. He's a distinguished medical professional and leader in the field of infectious disease, currently serving as the head of the Department of Infectious Disease, HIV and Tropical Medicine at Apollo Hospital, Chennai. With an exemplary academic background, including MBBS, MD, MR, CPK UK, and diplomas from prestigious institutions such as London School of Tropical Medicine, he has founded several notable initiatives like Immune Boosters, Capstone Multi-Specialty Clinic, and the Capstone Cares Foundation. He is also former president of the Clinical Infectious Disease Society of India, showcasing his enduring contribution to medical education and public health advocacy. He will speak on approach to adult vaccination. Over to you, Dr. Ramasubramaniam.
Yeah, thank you very much. Good morning to all of you. And I thank the organizers for inviting me to speak at this conference. Unfortunately, since I was in Sri Lanka only a couple of weeks before for a personal event, I couldn't join you in person, though I would have loved to be there. I love Sri Lanka, so it's a pity that I'm not there today. I shall, over the next 20 minutes or so, be talking to you about the approach to adult immunization. Adult vaccines are accepted very well in the Western world, but somehow in countries like the tropical countries like India and Sri Lanka, there is still a lot of hesitation about adult vaccines. In fact, I would say that if you mention shots in India or even probably in Sri Lanka, the usual response is something like these. These are what is considered as flu shots because they probably help you when you feel lousy with a cold or an influenza. These seem to help you feel better. But it is very clear that the impact of vaccination has been understood in children. It's been said that with the exception of safe water, no other modality, not even antibiotics, has such a major impact on mortality reduction. Not only mortality reduction, it decreases morbidity and improves productivity also. But what we fail to realize is as we grow older, adults also need vaccination because the immune system starts weakening. Beyond the age of 50, there is a very steady decline in the immune response in adults, what is called as immunosenescence. Now, this immunosenescence increases the risk of developing certain diseases and also increases the complications due to infections like flu or pneumococcal infections, which may be milder in younger adults, if at all. But you also have to understand that immunological age is not the same as a chronological age. There are other factors which impact the immunity. The nutritional status, the occurrence of comorbidities like diabetes, heart disease, lung disease, kidney disease, liver disease, the lack of physical exercise, and genetics to a certain extent. So all these impact on the immune response in a person as he grows older. And to this, you add the risk associated with other comorbidities, which could be hypertension, as I said, diabetes, cardiovascular diseases, lung diseases. These join together and can increase the risk of infections and the risk of complications also. So for all these reasons, adult vaccination is very important. Apart from immunosenescence and chronic illnesses, the inability of childhood vaccination to offer long-term benefits, the changing disease epidemiology with the occurrence of certain newer diseases which may emerge as you grow older, it is very important that all of us, not only doctors, but even patients, are recommended vaccines to keep them healthy. Not only keep them healthy, it has been shown that vaccines have helped eradicate disease. And extending it beyond, it has been shown that immunizations are a very good, healthy return on investment. This picture shows you the various interventions which bear results, and you see that immunization in adults comes right on top. So this increases the productivity, this makes a person work better, improves the returns, and thereby the money spent on immunizing adults is definitely worth it. So based on all these evidence, the World Health Organization has recommended what is known as a life course immunization. That is, as you grow older, you need the vaccines, not just the childhood vaccines, but depending on the age, depending on the travel, depending on the other situations like pregnancy, you need to have certain vaccines which are tailored to suit your needs. In fact, there is a very nice acronym called HALO, H-A-L-O. H stands for health, A for age, L for lifestyle, and O for I forget what O is. I'm sorry. So based on this, your necessity for vaccination can be determined. Even when you're looking at travel. So if you're going to travel, the kind of travel requirements you need. Are you going to do adventure travel? Are you going to do a sedate travel? Are you going to be trekking? Are you going to be in the forest? Or which country you go? All this defines the vaccination requirement of an individual. So the Advisory Committee on Immunization Practices, which advises the CDC in the US, comes out every year with recommendations for adults. Now, this is the broad recommendation which is given based on the age. There are also other recommendations based on the occurrence of comorbidities. If you are HIV positive, if you have had a splenectomy, if you are pregnant, if you're a healthcare worker. So this can be accessed on the net, and this will tell you, depending on the age, what vaccines are recommended for you. Now, this is all very clear. You can get all these data, but I'm going to say a few more things about the importance or the impact adult vaccinations can have. Now, let us take, for example, pneumococcal disease. As you grow older, let us say if you have a COPD, the incidence rate of community-acquired pneumonia was 22.4 events per 1,000 person years in the 10 years after the diagnosis of COPD. If you're a diabetic, it increases the risk of developing community-acquired pneumonia by 1.5 times. If you're asthmatic, that's an independent risk factor for pneumonia, and there is a higher risk of almost 13% of pneumonia occurring. And if you are a smoker, especially if you are elderly, it increases the risk of both community-acquired pneumonia and morbidity associated with this. So this is very clear. And if you look specifically at invasive pneumococcal disease, these risk factors can add up. A diabetic is almost 6 times at a higher risk of developing pneumococcal invasive disease. Patients with chronic heart disease 10 times, alcoholics 11 times, patients with cancers 35 times, and patients who have hematological cancers as high as 60 times increase in the occurrence of invasive pneumococcal disease. So if you have a 70-year-old individual with diabetes, with chronic heart disease, alcoholic, his risk for developing invasive pneumococcal disease stacks up. So for all these reasons, as you grow older, beyond the age of 50, or you have comorbidities, you need to have vaccinations. Now, these are the ACIP recommendations for pneumococcal vaccine. This has been changing over the last few years, but this hopefully should be a concise recommendation. So if you have somebody between the ages of 19 and 64 with chronic comorbidities like diabetes, heart disease, lung disease, or liver disease, you need to give them a conjugate vaccine followed a year later by a polysaccharide vaccine. Remember that the conjugate vaccine should always be given first in an adult to improve the immune response. If the adult is over than 65, this was earlier recommendation. Currently, this age in several countries has dropped down to 50. It is the same thing. Pneumococcal conjugate vaccine, which is, say, let us say PCV13, followed by PCV23 a year later. If you have immunosuppressing conditions, then the conjugate vaccine should be followed 8 weeks later by the polysaccharide vaccine and one more after 5 years. Similarly, for cerebrospinal fluid leaks or cochlear implants, a conjugate vaccine followed 8 weeks later. So the interval is much shorter for immunocompromised individuals when compared to patients with elderly patients or patients with comorbidity. But there are newer vaccines coming up. What about the conjugate 20 vaccine, the PCV20? Now, this vaccine, it is believed that because it has a broader serotype coverage, one dose suffices. You don't need to follow it up with a polysaccharide vaccine. This is likely to be introduced in India in the next 6 months, and I hope you will get it in Sri Lanka also. What about the flu? Flu, everybody recognizes the problems with flu, but people still think of flu as a simple cold with a little body ache. Unfortunately, it is not so. As you grow older, in a diabetic, the risk of hospitalization increases threefold. The risk of heart disease in patients with underlying cardiovascular diseases increases 6 times, 3 times risk of stroke, 30% case fatality rate in COPDs, and almost 30% of all acute respiratory infections can occur in patients with flu. So flu increases not only your risk of respiratory viral infection and the morbidity associated with it, and as you grow older, the mortality, or even in young children, it can be a killer under the age of 5 years. It also increases the risk of cardiovascular and cerebrovascular attacks. Studies have very clearly shown that the flu vaccine is associated with a reduced risk of developing an acute myocardial infarction and, to a certain extent, stroke also. Hepatitis B vaccine is recommended now. It is part of the universal immunization program for children in India, at least, and I hope that is in the rest of the world also. But the CDC specifically recommends the hepatitis B vaccine for all unvaccinated adults with diabetes younger than 60 years of age. It has been shown that as you grow older, if you're a diabetic, the risk of getting getting hepatitis B is much higher, especially in those who are having insulin therapy. What about shingles? Now, this is a vaccine which has been introduced just in the last few years. Very clear correlation on this right side of the slide. You'll find that beyond the age of 50, there is a steep increase in the occurrence of shingles. So thereby saying that beyond 50, the immunosenescence associated with aging increases the risk of developing shingles. And there are other factors. People who are depressed, asthmatics, diabetics, chronic kidney disease, cardiovascular disease, COPD. You wouldn't normally correlate COPD with shingles, but COPD increases the risk by almost 1.5 times. And psychological stress, depression, or physical trauma can also increase the risk of shingles. So shingles is recommended for all people above the age of 50. In India, it is only licensed for people above the age of 50, but if they are younger, but with probably chronic kidney disease, immunosuppressed hematological malignancies, the vaccine is recommended on individual case-by-case basis as 2 doses, 0, the second dose between the 2nd and the 6th month. And like flu, it has been shown that the risk of getting stroke and the risk of getting myocardial infarction is much higher. Both herpes zoster, say varicella, and influenza can increase the inflammation in the blood vessels, leading to a atherogenesis and strokes and heart attacks. So along with flu vaccination, it has been shown that shingles vaccine also prevents complications of cerebrovascular accidents and cardiovascular accidents, which typically happen in a few months' time after a person gets herpes zoster. More so, this is a recent article which says that the Shingrix vaccine actually protects against dementia. Whether this is a correlation only or actually makes a difference, we still have to wait and see. But this is a very, very reasonably good study, which was just, looking at the people who had Shingrix vaccine and comparing them with those who hadn't got it. It was shown that even dementia can be probably protected from people getting dementia by taking the shingles vaccine. Of course, if you're going to the Hajj for the pilgrimage, it is a mandatory requirement. A meningococcal vaccine is recommended. Along with this, both the flu and the pneumococcal vaccines are also strongly recommended. So you've seen that the benefits of vaccination in the elderly, not just related to the age, with comorbidities and with travel, is very important. And there are certain newer vaccines which have also been introduced. The RSV vaccine, which has been around for the last few years, recommended for all people above the age of 70 and people above the age of 60 with increased risk of getting RSV, is now licensed in most countries and is likely to come to India in the next few months. There is also a vaccine for chikungunya, which has come. Apart from this, the yellow fever vaccine is currently the only legally mandated vaccine internationally. And earlier, the 10-year booster doses has now been modified to say that if you're visiting countries in sub-Saharan Africa or in South America where the risk of yellow fever is high, one dose will protect you for lifetime unless your risk is going to be very high or you are immunosuppressed. So looking at the benefits, both in terms of the morbidity, the mortality, the severity of illness and health, it has also been shown, as I said earlier, the productivity is better if those who are vaccinated are compared with unvaccinated people. And it actually benefits both the employers and the employees in terms of saving money by vaccinating your staff. But there is enough evidence for all this, but still, I would like to talk from the perspective of India, where I practice and have an adult vaccine clinic. The adult immunization rates are still low. In India, the adult immunization rate for whether it is pneumococcal disease, whether it is influenza, or whether it is hepatitis B, hover around just 2% or less than 2%. Why is that? We don't have a national program for adult immunization like we have for childhood immunization. There is a general reluctance among healthcare workers. In fact, I would say if you ask me what is the most significant obstacle for adult immunization in India, I would say it is the reluctance amongst the healthcare individuals who are worried about a proactive intervention which may have side effects. And unfortunately, the COVID vaccine also did not help this matter. There are issues with the media. Whenever something wrong happens, immediately it is publicized in the media. The legal issues. Do we need to take a consent for vaccine in India? Still not clear. There are guidelines in the West. In India, we have just come up with guidelines. The Association of Physicians of India came with guidelines just a couple of years ago, where the Clinical Infectious Diseases Society was also a contributor on what should be given for adult in terms of vaccination. Most of the patients don't want to take vaccines when they are feeling good, what we refer to as a optimism bias. This is a cognitive bias where the human rationality goes for a toss, because when you feel good, you think that you are invincible. And lastly, there is a problem with accessing the vaccines in India. So these are the issues we need to target. But most importantly, when people say vaccines, they expect that vaccination will keep them healthy for the rest of their life. You take one vaccine and it will protect you from all infections, something like a Brahmastra. It doesn't work that way, especially with the budget that people are willing to pay for. The Shingrix vaccine is unfortunately reasonably expensive when compared to the other earlier vaccines. So if you're looking at the approach to adult vaccination, you're looking at customization to suit the needs in your country. I'm telling you from the Indian perspective, we are improving awareness both among patients and healthcare workers. We need to customize the guidelines to suit our population. In India, there is a very high percentage of diabetics, which we need to keep in mind. We need to look at insurance companies which will give incentives, maybe lower their EMIs in people who have had their vaccines, because they stand a better chance of staying healthy when compared to non-vaccinated people. We need clarity in legal matters. We need to have the administration buy-in. When you have a hospital administration, we need to establish adult vaccine clinics. We have a very good clinic in Apollo. I've got a very good clinic in my capstone clinic. So you need to have support from the administration to get establish an adult vaccine clinic where people can access the vaccines easily. You need to subsidize if necessary. You need to integrate specialties. Adult vaccination is something which is an orphan, because every specialty uses it, whether it is cardiology or whether it is nephrology or diabetology or pulmonology, they all use it, but nobody takes onus for this. We need champions. Recently, we had Amitabh Bachchan, who is now a brand ambassador for the Shingrix vaccine. But how many people can afford to, hire Amitabh Bachchan as a champion to sell their products? And as I said, we need adult vaccine clinics to improve access for the vaccines. But if you ask me who has the most influence on an adult deciding the vaccine, it is actually the personal physician. So if the patient's personal physician recommends an adult to take a vaccine based on his risk factors, that is the most important influence to get the patient to take the vaccine, irrespective of the cost. And this I can tell you by personal experience. But lastly, we also need out-of-the-box thinking. If you're going to make adult immunization something which people will ask for and take, you need to make it more attractive. Look at this, you are giving them at a discount. And something like this maybe, are you an alcoholic? We can help. We give liquor home delivery. So this kind of an out-of-the-box thinking is very necessary for enticing both the healthcare workers to recommend the vaccine and the general public to take the vaccines. So I leave you with this message. Please remember that vaccines do not save lives. I repeat, vaccines do not save lives, vaccinations do. So there is no point on having a vaccine in your refrigerator unless the patient is recommended, offered, and given the vaccine. It's not going to make any difference. Thank you very much.
Thank you very much, Dr. Subramaniam, for that excellent lecture. We can allow you one or two questions from the audience.
Ramesh, excellent lecture. But Ram, even among 15 plus years of SIDS, it is only Ramsub who is particularly successful in adult vaccination. Why is that?
Hi, Ramesh. Good to see you. I wish I had been there to join you. It is basically, as I said, it is an orphan. Nobody wants to take it up. You need a passion, you need grit and persistence. And there are far more lucrative or more attractive things people like to do rather than push vaccines. It's a very staid intervention, but to me, it's a huge, life impacting intervention. So that's why I'm sticking to it. And I would recommend, at least in Sri Lanka, I think all of you should take this up because it makes a huge difference in a patient's life.
I ask just one question. Dr. Ram, now in Sri Lanka, we have a small issue. We don't have PCV 13, and we substitute it with PCV 10. So no guideline, no recommendation, international guidelines all talk about PCV 13 followed with PPSV 23. What do you think about it?
No, I think that's perfectly fine. We need to create our regional recommendations. So till recently, till a few years ago, India also had that. So you have to give PCV 10 followed by PPSV 23. So it's just the same thing. You need what is available, but as I said, keeping it in the fridge is not the answer. You need to recommend it. You need to have your adults with comorbidities and the aging population take the vaccine 10 followed by 23.
Thank you.
In the interest of time, I think we move on to the next speaker. I will invite my co-chair to introduce the next speaker.
Our second presentation is by Dr. Suneth Angampudi, and the topic is going to be leptospirosis vaccine. And I'm sure it's a new topic for most of us. I think we in Sri Lanka, we have not even thought about or heard about, most of us, about leptospirosis vaccine. It's a problem in our country, and it's going to be a new topic. And Dr. Suneth Angampudi is a distinguished research scientist and a medical professional holding qualifications such as MBBS, MSc, MD, and MPhil. And presently he is working as a research scientist at IVI, International Vaccine Institute, Korea. His expertise has earned him prestigious roles, including serving as a visiting professor at Yale University and an honorary professor at Rajarata University of Sri Lanka, highlighting his significant contributions to the global medical and academic community. It's my pleasure to invite Suneth to do your presentation. There's some technical issue. Hopefully it will be sorted out soon. Okay, I think we can start now. Dr. Angampudi, have you already started your presentation? There was an issue, you had to restart. Can't hear you. Yeah, you can start now, Dr. Ambal.
Can you hear me now?
Yes, right, you can start off.
Thanks. All right, so I think you all can hear me now. So for the technical issue. Good morning, colleagues. Thank you for Infectious Disease Forum of Ceylon College of Physicians, ISID and CIDs for this kind invitation. It's an honor to speak here today to most of my colleagues. Today I'll be speaking about leptospirosis vaccines, the history, different approaches on leptospirosis vaccines, the public health challenges we face, and why this deserves more attention, especially in countries like Sri Lanka. So we will start with clinical reality, what you see in the wards most of the time in Sri Lanka. So we often think leptospirosis as classic Wills disease, presenting with myalgia, conjunctival hemorrhage, and jaundice. But some of you are already aware that it's not uncommon, especially in wet zones in Sri Lanka during the monsoons, seasons, or harvesting period. However, the disease is far more diverse than typical Wills disease. And those who are interested in leptospirosis, clinicians who are working with leptospirosis are aware of this one. If you talk to your colleagues from Gol or Kalutara or some other parts in South, they will describe increasing cases of pulmonary hemorrhage syndrome, patient with hypoxia, hemoptysis, and acute respiratory distress syndrome. And these conditions are often fatal without specialized care. And if you talk to your colleagues in Polonnaru or Anuradhapura, dry zones of the country, they might describe about renal involvement, primary renal involvement in leptospirosis patients. And then all around the country, you will see some atypical cases like acute abdomen, even presenting to surgical wards, meningoencephalitis-like presentations, and uveitis cases. Even though we see these are rare presentations of leptospirosis, this is not rare, especially if you are working in an area where the leptospirosis is endemic. So this variability of clinical disease itself is a challenge for us because early symptoms like fibromyalgia and headache, this may be presenting as just viral fever, and many of us will not think about leptospirosis. And there's a small diagnostic window, but we don't have enough diagnostic tools for leptospirosis diagnosis. Despite having antibiotics against leptospirosis, and leptospira is not having any resistance to non-antibiotics, people might go into complications because we don't diagnose them early, or they don't present to hospital early. And this disease diversity is mostly related to taxonomic diversity of leptospira. If you think about leptospira, it's not a single species that causing leptospirosis. There are more than 78 named species, and I'm calling it named species because there are some species, leptospira species identified, still not named or still not classified. Out of these 78 recognized species, there are 28 pathogenic species of leptospira. And within this pathogenic group, there are more than 260 serovars. And these serovars are mostly defined by surface lipopolysaccharides known as LPS structure. And this is important, especially when we are talking about vaccine development. And other than this 28 pathogenic species, there are 28 intermediate species, and then another 22 saprophytic species. So this species diversity is the central scientific challenge in vaccine development because it's really difficult to create or develop a vaccine which covers over 260 serovars. And this is the main challenge we are having for the last century in leptospirosis vaccine development. Someone might ask the question, why vaccine for leptospira or why vaccine for leptospirosis? What is the problem we are facing. And in countries like Sri Lanka, when I'm traveling from Colombo to Galle, which is my hometown, or when I'm traveling from Colombo to Anuradhapura, which was my previous workplace, I always see these agricultural lands, paddy fields, or urban environment with poor or inadequate sanitation, or water system, irrigation canals or natural water streams throughout my journey. And all these places, environmental places, are conducive of leptospira transmission. So leptospirosis is deeply embedded in our environment. Flood zones, paddy fields, irrigation system, poor urban drainage, everywhere you can identify leptospira. Even though we are reporting more than 12,000 cases per year in Sri Lanka, in documents, in official documents, we know that this is an underestimation. We know that treatment works, but only if started early. And early diagnosis is usually the exception because we don't have laboratory diagnosis for most of our cases. And the economic cost, which we are, as clinicians, we are not usually talking about, it's immense. And one of the estimate we did a few years back, it shows that over $2 billion international dollars cost, it's the average cost for productivity loss for leptospirosis in Sri Lanka. This is not treatment cost or hospital cost, just the productivity loss. And leptospirosis being a disease in poverty, it's about public health justice, and that's why we need prevention more than treatment. So coming back to the main topic today, evolution of leptospirosis vaccine. The leptospirosis vaccine work started in 1920s in Japan. So it was more than a century-old story. And they started developing whole cell vaccine using formalin inactivated whole cell vaccine, which is known as BAC3 to protect military personnel. So this formalin whole cell vaccine was later used in mid-20th century in China, Cuba, and also in France, and it becomes the only leptospirosis vaccine used in large scale in human use. Of course, some of you are already aware, those who are having dogs, you are aware leptospirosis vaccines are available for veterinary use for dog, cattle, and other veterinary practices. It's there, but human vaccines, it was only in these 4 countries. I will come back to those 4 countries to explain how they have used this leptospirosis vaccine. And late 20th century, after recognition of vaccines limitations, side effects, and then reduced capability of addressing different serovars, people start looking at next generation vaccines and looking at different targets. So this recent scientific community advances in these platforms, including subunit vaccine, DNA vaccine, and tools like reverse vaccinology. I will touch upon this later in this presentation. So coming back to whole cell inactivated vaccines for leptospirosis and mechanisms and limitations. So this is very simple. Anyone who is aware of vaccine usually know about the whole cell inactivated vaccines. If you think about some of the vaccines we are using in our EPI program, like pertussis vaccines we used earlier, whole cell vaccine, it's an inactivated vaccine. So these are called bacterial vaccines, as I mentioned earlier. And how do we prepare these vaccines? Usually we grow large quantities of pathogenic leptospira and then inactivate them with formalin. When you do that, these bacteria, they retain their surface structure, mostly LPS and other outer membrane proteins like lipel-32, lipel-41, and OMPL1. So all these are important in pathogenesis. And when you're having all these surface structures, it triggers a strong immune response. And this initial immune response is innate immune response, and it's followed by IgM-based response in leptospira vaccines. The issue of wholesale vaccine in leptospirosis is that IgG develops only after multiple doses. So with a single dose and even with 2 doses, usually they don't have IgG response. So that's why it's only short-lasting response. So the protection is only short-lived, lasting only 6 to 12 months and only effective against the included serovar. So if you are using only a single serovar, the vaccine will protect only against that serovar, and there's very little cross protection. And our understanding on this prevalent serovars causing human disease, it always shows that there are multiple serovars at any given time. If you look at the Sri Lankan example, if you look at studies done in Sri Lanka, especially in Kandy, Matale, Kegol, Anuradhapura, Ratnapura, Avisavilla, and even in Galle districts, if you look at zero identification, you can see at any given time, there are more than 3 or 4 zeros circulating. And so it will not cover, if you are using only one zero, it will not cover other zeros. And there's another issue of a leptospira vaccine using wholesale vaccine mechanism. The immunity is non-sterilizing. So that means in animal studies, it shows that it will prevent disease, but it will not prevent leptospira shedding. So it will still remain in kidneys and shed them in urine. So we don't have human data on this specific aspect, but we know with the animal studies, especially hamster studies, that it's non-sterilizing immunity that we are talking about in wholesale inactivated vaccines. As I mentioned, so Japan was the first country to do this vaccination program using wholesale vaccine. And they used 3 serovars, Hebdomedis, Canicola, and Icterium hemorrhagiae. The large-scale programs, they started in 1960s, and they had target population. They started with military personnel, and then they had rice farmers, irrigation workers, and meat handlers. But in 1970s and 80s, that they realized that the side effect profile is much more than they expected. And by early 2000, they phased out this vaccine due to these problems they are having. It was effective, but more than vaccine, urbanization and sanitation improvement, it reduced the disease incidence in Japan, and they combined with the need for repeated boost doses and the narrowed protection, though they phased out the program in early 2000, and they are no longer producing or using leptospirosis vaccine. China is the country which used the largest vaccination program in history against leptospirosis. By the late 1980s, they started developing, early 1970s, they started developing leptospirosis vaccine. And in 1980s, they immunized more than 1 million people in seasonal campaigns before harvest and before monsoons. And based on their data, published data, the vaccine efficacy range between 83 to 93% when matched with circulating strains. But if it is not matched with circulating strain, the efficacy drops even below 50%. So they have some of the published data in, as an example, in Gongex province, human incidence dropped over 30 per 100,000 to 5 per 100,000 with the vaccination program. But then when other serovars start circulating, it starts rising again. And the Chinese experience, so they had 2 types of vaccines, one from Institute of Medical Biology and another one from National Institute, and they are using different serovars. And the first vaccine included Leptospira, Icterium hemorrhagiae, and Canicola, and then later they added Pomona and Autumnalis, but still this was inadequate to cover all the circulating strains. Then come to Cuba's emerging response strategy. This is an interesting strategy they are using. And even China, they stopped their vaccination program. Cuba is a country who are still producing and using leptospirosis vaccine. So Cuba developed a bivalent vaccine targeting Canicola and Icterium hemorrhagiae in 1990s. And their approach was on protein immunization. But they use this vaccine as rapid emergency response during floods and hurricanes. In 2007 and 8 hurricane period, Cuba vaccinated over 2 million people within weeks following the flooding. And during this time period, they reported effectiveness ranging from 70 to 85%. But after that, we don't have enough data to show the effectiveness in different time period. But still, Cuba is using this as part of their emergency response. Then we have France Virolept, again another wholesale vaccine. They are using occupational model. So this France monovalent vaccine. So this is a monovalent vaccine. So it's slightly different from other vaccines in Cuba.
Dr. Angampuri, we have only another 5 minutes for the presentation.
Okay.
Only 5 more minutes
Thanks.
for the presentation.
So their approach was to immunize only selected occupational groups using icterohemorrhagia, but again, we don't have enough data or clinical trial data on France vaccine. So new approaches in leptospirosis vaccine development, we have subunit vaccines, DNA vaccines in pipeline, but all these vaccines, so subunit vaccine, they use purified antigen, usually Lig-A as a star candidate. And so we have hamster data showing that it's providing sterilizing immunity, but it's very early stage. Similarly, we do have DNA vaccine programs going on in Brazil and USA, but still having preclinical data only. We don't have a proof of concept on both these vaccines. We also have vector-based vaccine platform and reverse vaccinology using against leptospirosis. And vector-based platforms, it seems like vector-based platforms are better than other platforms, but still similar to other vaccine approaches, still in preclinical stage. And only vaccine which is in proof of concept stage right now is VM protein vaccine targeting virulence factors led by Yale group, which I'm also part of this vaccine development approach. So they are using pan-leptospira vaccine using highly conserved proteins, and they have promising results in hamsters and dogs. So problems or challenges in vaccine development is mainly the funding limitations, because leptospirosis is still not an NTD listed in WHO, and therefore funders are not having enough fund allocation for vaccine development. So scientific hurdles are there, as I mentioned, about diversity. And then we need, for path forward, we need burden estimates, because without having proper burden estimate, funders will not be interested in this vaccine. And we need translational research, clinical deployment, first in human trials. At least within next 2 years, we are supposed to have the first in human trial for leptospirosis vaccine. And then we have to think about how this global access will work for leptospirosis vaccine. So in closing, leptospirosis scientific challenge. It's also a matter of justice, because we are dealing with the disease in poverty. And people most at risk are the ones least protected by diagnosis, by treatment, or by policy. If we succeed in developing a safe and effective vaccine, it will be a public health win, but also it's not only a public health win, but also an ethical one. And thank you very much. I look forward to your questions.
Is open for questions.
Thank you. Congratulations, Dr. Sunit Tagampudi. I'm Dr. Vimsri Uluwattagi for your informative lecture. And we are, as Sri Lankan, we are proud of what you are doing there. And one question, we know that vaccine against animals, especially dogs, are said to be effective, and it's been widely used all over the world. But what is the difference between the one vaccine against animals being effective, and why not against humans?
So there are two main reasons. The first one, animals, the strains which are causing animal disease is very specific. Now, as an example, most of the dog disease is due to strain Canicola. So it's easy to develop a vaccine against single strain. And similarly, for cattle, it's against Hebdomedis, or pigs, it's against Pomona. So that's the first one. That's the scientific challenge. And the second one, developing vaccines against dogs or animals is easy because they usually don't complain about side effects. So side effect profiles with killed wholesale vaccine for human, it's not acceptable, even though it is acceptable for animal. So these are the two main things that differentiate the human vaccine and animal vaccine.
We do have a bit more time, Dr. Angapudi. Can you just elaborate a bit on the work that you all are doing at IVI, the type of vaccine and what level, what phase are you in now?
So at IVI, actually, we are supporting the vaccine developed by Yale group, Professor Joseph Binet's. So they are using this VM protein. So this VM protein is highly conserved protein. This protein is only in pathogenic species of Leptospira. And this protein, in preclinical models, they have shown that blocking this protein can reduce, or not reduce, actually, they can block the pathogenic pathway and then reduce the disease in hamsters and in dogs. So this is at a proof of concept. They are facing some challenges in process development, because even though the target is there, it's difficult to create this protein as a vaccine. So they have to have this development process, and they have to detoxify the vaccine. So IVI is trying to help them on getting grants to detoxify the vaccine and do the process development. And if if it is successful within next 2 years, then it can go to a phase 1 trial. But again, so this is another bottleneck usually we are having in vaccine development. Even though we are having good vaccine candidate at proof of concept level, it will not always go to a manufacturer level or phase 1 trial level, because process development is not easy. So right now we are in that process, and if it is successful, then we can go to phase 1 trials in 2 years' time.
Okay, thank you very much, Dr. Angapudi. Thank you for that presentation. Thank you very much. The next will be our third presentation, and I will invite Dr. Madhuvanti to introduce our speaker.
Thank you. Our next speaker is Professor Lance Turtle. He's the chair in immunity and infectious diseases at the University of Liverpool. He's an esteemed researcher and honorary consultant physician, and he's specialized in arbovirus infections and with a focus on immunity, vaccines, and neurological infections. And his work spans on viruses like JE, dengue, Zika, and chikungunya. And I would like to invite Professor Turtle to talk on JE vaccine. Over to Professor Turtle.
Thank you very much. Good morning from me, probably good afternoon from you. I'd like to thank the organisers for the invitation to speak. It's a very kind invitation for which I'm very grateful. I'm sorry I can't be there in person. Can I just check you can hear me okay and you can see me if you need to on the slides?
Yes, we can hear you clearly.
Great, okay, lovely. So I can just work out how to advance the slides. Okay, so I don't think I need to tell this audience that Japanese encephalitis is caused by a virus that's part of the flavivirus genus. So this includes a number of other very significant global viruses, several of which are a big problem in Sri Lanka, such as dengue, for example. The genus gets its name after yellow fever virus because flavus is the Latin word for yellow. So JE virus exists in an enzootic cycle throughout South and Southeast Asia. It's naturally a virus of birds, and it's passed between birds by mosquitoes without really very much being apparent to humans by that transmission cycle. The virus can also infect some peridomestic animals, such as pigs. In countries that have pigs, there are also countries in Asia that don't have big pig populations, but do have things like domesticated birds, which are also susceptible to infection. And what that does is it brings a reservoir of virus physically closer to humans, and the mosquitoes that feed on those peridomestic animals can then bite humans, and that can result in human disease, which is humans are actually a dead-end host for JE virus. So JE virus does not replicate to high enough levels in humans to be onwardly infectious. So for the virus, this is actually a dead end. This is a kind of accidental event, if you like. The majority of people who are infected won't develop any disease at all. Only a small proportion, much less than 1%, will actually fall ill. But of those who get ill, the illness is very severe, and quite a large fraction either die, unfortunately, or have suffer lasting neurological defects. So probably around 20% or something die, give or take. The reports in the literature are quite variable, and around about double that number, about 40% probably are left with permanent neurological damage of some kind. You can see in those photos there the kind of environment which is suitable for replication of the mosquitoes that transmit JE virus. It's transmitted by mosquitoes of the Culex genus, such as Culex tritonuricus, which is abundant in rice paddies across Asia, and you can see a picture of that down there. So the virus probably originated in Indonesia because that's the only place where all 4 genotypes of the virus are found, and then spread throughout South and Southeast Asia. Historically, genogroup 3 has been the genogroup that's caused most human infections. That's probably still true, although most human infections cannot be grouped because virus isn't isolated or detected. But in nature, isolations and detections of genogroup 1 are also now increasing beyond those of genogroup 3. This is a virus which has the potential to move to different regions. So this illustrates the major bird flyways across Asia and Africa and parts of Eastern Europe. And you can see these overlap quite substantially. There has been a single detection of Japanese encephalitis outside Asia. That was in Angola in, I think, 2016. And that was a whole genome was identified in a patient who also had yellow fever. And I don't think any of us really know quite what to make of that. There have been no further detections, no suspicion of any cases in Africa, at least not that I know of. And this patient also had yellow fever. So just to have yellow fever and JE at the same time seems to be awfully unlucky and unusual. So I don't quite know what to make of that. But there's this one observation which sort of sits there unclear as to what that really means. You'll also see that Australia is now indicated in this map, and in 2022 there was an outbreak in Australia. So Australia, the Torres Strait of Australia, to the north of Australia, is quite close to Papua New Guinea, and there have been cases in the Torres Strait historically, and there have been 1 or 2 cases in northern Australia. There had been identifications of JE virus on the Australian mainland going back to the late 90s, but then for reasons which are unclear, in 2022 there was a big outbreak in southeastern Australia centred around piggeries, as you might expect, a good amplifying host, and there were about 45 odd human cases, I think, and about 7 deaths, and this lasted for about 1.5 years and then just burnt itself out. So where it came from, we don't know. Where it went, we don't exactly know, but it illustrates that this is a disease that does have the potential to move. We don't quite understand what factors restrict it in its current geography, but this illustrates that those factors are obviously subject to change, and it can potentially move, making vaccination as a public health response a highly relevant thing. It was genogroup 4 that caused this outbreak, so also relatively unusual genogroup for humans. So what about diagnosis of JE then? So the diagnosis is usually confirmed by anti-JE virus IgM in CSF. There are also other ways of making a diagnosis, detection of antigen, detection of genome, or isolation of virus. Those are very uncommonly done because they're very difficult to do. So in general, in these cases, there is probably a brief period of viremia followed by the virus entering the central nervous system, at which point it is relatively inaccessible to diagnostic tests, because obviously, as you all know, it's much harder to sample the brain than it is, for example, the blood or the cerebrospinal fluid. And you generally don't detect viral genome in blood or CSF. You do occasionally, and clearly that is enough to confirm a diagnosis. The traditional method of confirmation was a fourfold rise in circulating blood antibody titer by either hemagglutinin inhibition or neutralization assay. And that, of course, requires you to do clinical follow-up and get convalescent samples. So it's quite useful in a research context, but it's often not done in a clinical context. WHO recommends that this is done in all JE endemic areas as part of syndromic surveillance for acute encephalitis syndrome. So this happens in Sri Lanka, for example. And then the acute encephalitis syndrome cases are divided up into lab-confirmed, epidemiologically associated, which usually mean cases associated with an outbreak, but where CSF isn't sampled or testing isn't done, and then cases where tests are negative, and cases where there's no outbreak and testing is not done or is negative. The AES other category, again, can involve identification of an alternative cause, such as scrub typhus, chikungunya, HSV, etc. So one of the observations that's been quite clear historically on the effect of JE vaccine is that JE vaccine campaigns also reduce all-cause acute encephalitis. So they also reduce that fraction of encephalitis in children, which is either not diagnosed or tests JE negative. And the reason for that is this. The reason is that it takes actually up to 7 days before you get the peak positivity rate of IgM in CSF, and quite often CSF will be sampled earlier than that on presentation. If a clinician is suspicious of a diagnosis that needs immediate treatment, like bacterial meningitis or TB meningitis. So a fraction of patients will test falsely negative. And as we all know, once no treatable cause is identified, there is a tendency for people not to want to do more invasive procedures and resample, because it doesn't change the management of the patient very much. But actually, if you do that, you do pick up more JE cases. So the overall burden of JE is usually an underestimate, and vaccination campaigns have a greater effect than you would think. So there are two contexts then for JE vaccination. There is that which we would do in the UK, where I practice. So there's travel-related use. So this would be selected individuals based on a risk assessment according to where they're travel to a JE endemic area, and that's then privately funded. So the patient then pays for the vaccine themselves. And then you would have that in an endemic, or it might be better to use the term enzootic area, such as Sri Lanka and many other parts of South and East Asia, where the vaccines are used at population level and they're part of a national or regional program and therefore are publicly funded. And indeed in Sri Lanka, as I'm sure you know, it's part of a national immunisation schedule. So for travel-related JE, we make risk assessments based on the type of travel that the person is doing. So obviously, if they're in a JE endemic area for longer, that increases the risk. The risk is generally greater the further south you go. If you have urban travel versus rural travel, so you're more exposed to that. Urban ecosystem with the mosquitoes, which can transmit JE. If you have accommodation which is full of holes and can't effectively exclude mosquitoes, then your risk is greater. And if you're outdoors at times when the mosquitoes are more active, then that's also going to increase your risk. And of course, bite avoidance, such as using repellent in a net, would also be expected to reduce the risk. And then there are some factors within the individual that might put them at increased risk of disease if they did get JE infection, such as immunocompromise and also breach of the blood-brain barrier, such as previous brain surgery or a CSF leak or anything like that. So we've seen we reported a few years ago 3 JE cases. We've had, we think, actually 2 more since then. So we've had 1 confirmed JE case. So we've had 4 definite cases this century, and we have possibly had a 5th now as well. The last report before that being in 1992. And I just show this slide to make the point that in adults, so in travel medicine, although the disease is very uncommon, it is very, very serious. So of these 4 patients, 2 of them have ended up paraplegic, ventilator dependent, needing gastrostomy feeding. And the other 2 have recovered well because of their young age, but one of them suffered a cardiac arrest and needed resuscitation and intensive care, and the other one suffered a stroke and got brain swelling and needed an emergency decompressive neurosurgery. Now, both of those patients made excellent recoveries. You might be surprised to hear from that severity of illness because they were very young. They were, I think, 20 or 21, and they went into the illness fit and well. But you can imagine that an older patient would really suffer under an illness that is that severe. And one of our patients had stereotactic neurosurgery in the past, so 1 out of those 4, just emphasising that point about the identifying risk factors for travel-related vaccination. So what about Sri Lanka specifically then? So JE emerged in Sri Lanka as a public health problem in the 80s, although the virus had been known to be present in the country for decades earlier than that. JE vaccination began in the late 80s, first with the inactivated mouse brain-derived JE vaccines, and then it moved to the Chinese-made live attenuated JE vaccine in the early 2000s. And this has really been a great success. And you know, again, as you will know, there is really no JE in Sri Lanka now. There have been only sporadic cases since 2003. And as has been seen in other countries like Korea and Japan that have also had successful control programs, the epidemiology has shifted somewhat to affecting older people where antibodies can wane late in life. And there's a very clear, you know, in the sort of Pan-Asian data, there's a very clear signal that being late in life is potentially a risk factor for developing JE, even if you were vaccinated in your youth in an endemic area. So what vaccines are available? The one that's most commonly used and the cheapest around Asia is the Chinese primary hamster kidney cell derived SA1414-2. That's made by Chengdu Biological Products in China. There are a number of earlier vaccines made with mouse brain. These have been phased out now because of a perception of a risk of acute disseminated encephalomyelitis as a side effect. Whether that was really caused by those vaccines or not was not totally clear, but clearly the risk was too great to take that chance. Those vaccines also have much worse side effects in terms of systemic and local, you know, the kind of pain, injection site pain and systemic reactions they cause were much worse. And there's also a risk of anaphylaxis with them. And the newer cell culture derived vaccines are all much safer. There are really no serious adverse events associated with these vaccines. They're generally very safe indeed. There are some inactivated vaccines made in Japan as well. Internationally, the main inactivated vaccine that we use is this one made by Valneva, which is marketed as Ixiaro. It has a different name in Australia and New Zealand. It's called JE Spect. The developmental code was IC51. So if you read old trials, you might see this term IC51. There is now an Indian domestically manufactured vaccine from an Indian isolate called Genvac, made by Bharat Biotech. And there's the JE was also the first disease to be targeted by a recombinant vaccine. So this product called Imojev, also known previously as Chimerivax JE. So this uses the same technology as the Sanofi dengue vaccine, Dengvaxia, which, as I'm sure you know, was not a great success. But for JE, this was much more successful, though the market is much smaller. And this is a yellow fever virus backbone with the JE virus pre-membrane and envelope protein cloned into it. So it's basically a virus particle that's like JE virus on the outside and yellow fever virus on the inside. And that's available in Australia, New Zealand, and several countries in South and Southeast Asia. So what about the efficacy or effectiveness of these vaccines? So actually we have relatively little data on efficacy. There's only really one clinical trial that's available, and that was done on the inactivated mouse brain derived vaccine in the 1980s in northern Thailand by a sort of collaboration between the US and the Thai military. And this tested two different vaccines, a monovalent and a bivalent vaccine. But actually at the time, JE virus was only sequenced around about the time, I think it was the year before, 1987. And so no one knew anything about genogroups of JE at the time these vaccines were made. And they're both from genogroup 3. Indeed, all the vaccines that are available are from genogroup 3, but they seem to provide pan-genotype protection. So that we don't actually expect a big immunological difference between these two vaccines. But the efficacy in this trial was 91%. So that was very, very solid clinical evidence that vaccination works against JE. There have then been some sort of real-world effectiveness studies, case control studies from Nepal, for example, showing high vaccine effectiveness. Around 95 to 99%. So we know that the vaccines work. Not all studies are quite as conclusive as this. There's one or two studies in India which cast a little bit of doubt on this degree of effectiveness, but the weight of the evidence is that vaccination is effective. And I think the experience in Sri Lanka also plays that out. So what about immunogenicity then? So the newer vaccines such as IXIARO, this is a cell culture-derived inactivated vaccine. These have not been tested with disease as an endpoint because that's no longer ethical to do. So these were compared with the existing mouse brain licensed vaccine, and the seroconversion rate is very, very similar, and these are adequately immunogenic, and they have later vaccines have been licensed based upon their immunogenicity, looking at antibody as a correlate of protection based on data from that original Northern Thai trial from the 1980s. So just a word about duration of immunity for IXIARO, because one of the concerns about an inactivated vaccine, especially in travel use where people are not repeatedly exposed to the virus, is the duration of immunity. So seroprotection after a 2-dose primary course is high, in the high 90s, but that wanes after 6 to 12 months. So by about 12 months, it's about a little bit less than 60%. It's worth noting there are animal models of JE where priming of memory B cells without circulating antibody is also protective. So it may be that somebody who's vaccinated, whose circulating antibody has waned, still does have a degree of protection. But clearly, if you have a high level of pre-existing circulating neutralizing antibody, that's going to be better. And in this study, participants who had a primary course were revaccinated, and again that showed very high level of protection 2 years later, and some resampling and modelling studies showed that the majority are still seroprotected after 6 years. So if you have a primary course followed by a booster dose 1 to 2 years later, then you're covered for quite a long time. And in practice, what we do is we give a booster dose irrespective of the timing. So if you've had a JE primary vaccination course 10 years ago for a trip, and then you come to a travel clinic, on another trip to Asia with a perception of a risk of JE, you'll get given a booster dose irrespective of the sort of time that's elapsed. There's Imojeb, so this is the Sanofi recombinant vaccine. So this in young children gives high antibody levels early after vaccination. These do wane over time, so boosting is probably advisable. I'm not aware this vaccine is used very much actually in the vaccination campaigns in endemic areas for young children. It's mostly the Chinese SA1414-2, which I showed you in the effectiveness slide. But if you use Imojeb as a booster following pretty much any primary course, you see very high seroprotection. So it's certainly useful as a booster. And I think the available evidence suggests that you can mix and match JE vaccines without really any significant considerations of immunogenicity. And in adults, adults after a single dose, a long-term protection is a bit better than it is in young children. So what about safety? So if you look at the more recent trial, so the mouse brain derived vaccine now has been studied a long time ago. The Chinese vaccine, again, has been studied in several trials now outside China, but I'm not going to say much more about those. The more detailed data we have is on the vaccines available for travel use, such as Ixiaro, and they have a much lower rate than the previous comparator mouse brain derived vaccine. So here in blue you see Ixiaro, and in purple you see a mouse brain derived vaccine. So there's a very big reduction in side effects by using the cell culture derived vaccines, and that's kind of seen across all the different cell culture derived vaccines. So there have been some sort of aggregate reports on safety recently, and they're all very reassuring. The overall rate of adverse events following immunization is small. I'm sure there's a surveillance system like this in Sri Lanka. I confess I don't know the detail of what that's shown in Sri Lanka, but there are no reports that I know of that give rise to any safety concerns with these vaccines. There are a few contraindications for the live Chinese vaccine, which is what's used in the Sri Lankan program. Pregnancy and immune suppression are contraindications. Of course, that's not a big consideration in young children. And the same is true for Imojev, which is based on yellow fever. So Imojev, although it is in reality probably safer than yellow fever, actually, the contraindications are felt to be the same. So age less than 9 months is a contraindication, and pregnancy and immune suppression as for any live vaccine. And there aren't really any contraindications to Ixiaro, apart from allergy to a vaccine component. I've only ever heard of one person who couldn't have a second dose, who had a severe allergic reaction to the first dose, but they had been given a different vaccine. I think it was a rabies vaccine at the same time. So, of course, we don't know which vaccine was responsible for that allergic reaction. And, of course, you pretty much can't have a history of allergy to a vaccine for a vaccine that's given as a single dose, because by definition, when you're vaccinated, you haven't had a previous dose. And it's worth setting these contraindications against potential risk factors, particularly in travel medicine. But in an endemic area or in an enzootic area such as Sri Lanka, then this is done as part of a campaign, and it's not really a big consideration. So if you want to read it, the UK Green Book gives you more detail on this, and there's a similar publication for from the US. I forget the name of it now. I won't dwell on this because it's not very relevant to Sri Lankan practice. But the balance of this in travel medicine, at least in Europe and North America, is that the risk of developing JE is tiny, it's minuscule, but the consequence of that is extremely serious. And the vaccine, but that you have to set that against the cost of the vaccine, which can often be a barrier. And we have a sort of constant kind of struggle to remind travel medicine practitioners, who most of whom have never seen a case of JE, how bad a disease it really is. But in a country like Sri Lanka, with a successful vaccination control program, as I say, that's not really a big consideration, because hopefully children are all being vaccinated, at the scheduled time around the age of 1, and the disease is under good control. So that's all I have to say. I hope I've given you a feel for the vaccines that are available, and a feel for the difference in their use and practice between an endemic or enzootic area, such as where you're based, and a country where I'm based, where it's largely travel medicine related practice. And I'll happily take any questions. Thank you very much.
Thank you very much, Professor Turtle, for that comprehensive lecture. In the interest of time, we can allow only one question from the audience.
Should the vaccination change towards, say, DNA vaccination or something like that, particularly if you're doing mass campaigns in endemic areas due to cross-reactivity or ADE to dengue?
Yeah, good question. There's no good evidence that the vaccine causes ADE of dengue. There were some studies in northern Thailand, again, showing that natural JE exposure might predispose to worse dengue, actually. So I suppose that would be an argument the other way around. You're right, there is a concern about any flavivirus vaccine, new vaccine, and dengue. Of course, the other solution to that would be to vaccinate against dengue. actually dengue is protective against JE. So if you've had dengue and you subsequently get JE, there's quite good evidence that your illness severity is a bit less, the illness is milder. I mean, I think I would probably argue that in a vaccination campaign, what one should be doing, this is not shown yet, but I think this is, the experiments of the future, if you like. We should probably be vaccinated against dengue first, followed by JE, and then that cross-reactivity is more likely to be beneficial, I think. I don't think that DNA vaccination would help. I don't think there's a way round vaccinating without introducing some cross-reactive antibody to dengue. The reason being that the way that flavivirus particles are neutralized, I mean, I haven't talked about this in the talk at all, but it's quite difficult to neutralize a flavivirus particle. They've got a type 2 fusion protein which lies flat against the viral surface. And during infection, that protein undergoes a dramatic conformational rearrangement and the fusion loop is exposed after it's actually entered the target cell. And that fusion loop antibody, that fusion loop is very immunodominant in humans, and anti-fusion loop antibody is very cross-reactive and very poorly neutralizing. And the mechanism of neutralization actually of any flavivirus is probably locking those type 2 fusion proteins together so they can't undergo that conformational rearrangement. So actually, I don't think, I've come to the view that I don't think there is a strategy for developing any flavivirus vaccine without some degree of cross-reactivity. That there are strategies that can reduce fusion loop exposure, like covalently linking envelope proteins together, and that can reduce it somewhat. But I think that absence of cross-reactivity isn't realistic. So I don't actually see that we need new JE vaccines. I think we've got good ones. Just a question of using them, as shown in the very successful program in Sri Lanka.
Okay, I would like to take this opportunity to thank all three speakers who have joined us virtually on behalf of Ceylon College of Physicians and Infectious Disease Forum. And that concludes the symposium on vaccination. Shall we thank them in our traditional way?